Thank you, Chair. So I'm going to continue, I think, a bit with this line of questioning. So the Neighbourhood Rebuild Programme states that we're going to get 250 new centres by 2050. So Martin, based on what you've just said, do you think we're going to get 250 new centres by 2050?
2050, do you say, is it?
Is that right?
2035, I think.
2035. Well, there you go, I was giving you more time. Less time. 2035, yeah, so less time, Martin. Sorry about that. We're down to like 9 years now.
Look, I believe that's entirely possible if you do two things. One, rework existing estate. That's really fast, expedient and much lower cost in our experience, and that's why we produced a document just before Christmas called Making Neighbourhood Health Centres a Reality. It's practical advice on how you can do this. There's two strands to this. One is utilise existing stock, which is underutilised, and you can do that pretty quickly.
And we've got quite a lot of existing underutilised stock.
Absolutely.
How many of these 250 centres do you think could be provided through existing stock?
So I can't really comment on the other 85-90% of the estate, only the 10% estate that we're owning and managing. But across our estate, we identified 160 properties that we believe are in the right locations, in the heart of the community, that with relatively low levels of capital investment could be brought up to the NHC standard. Now, we've been commissioned by the department to roll out 11 of these by next March. We'll do that. We could do more. But the first 11 of wave one, we will ensure that we execute on that.
Okay, that's interesting. Thank you. So thinking about the Neighbourhood Rebuild Programme and sort of reflecting on what you've said already around services that should be included in these health centres, I'm interested in the sort of the flexibility component of this and the idea of reducing burden on hospital care whilst at the same time actually providing proper neighbourhood health, because they are two different ideas which I think don't necessarily make easy bedfellows, but could potentially end up working together. So in terms of designing a space, I don't know, Martin, if this is yourself or Becky, if you want to say it, how easy is it to design a space that allows hospital sort of preventative services to be there alongside wider determinant, longer term neighbourhood health models? How easy is that to design?
I think with the right inputs, I think it's relatively straightforward. We're led by the clinical strategy, and it's up to commissioners to determine.
When you talk about clinical strategy, Martin, I'm interested in that as well. So if you get 250 different clinical strategies, is that still deliverable?
That's a good question. I'm not entirely sure I can comment on that. I'll be surprised if there's 250 different clinical strategies. There's a certain level, having seen the quite recently published archetypes for neighbourhood health centres, there's about, I think it's 3 or 4 different archetypes. Most of them have got a very common commonality in terms of certain services that clinical services will always be there. Then there's the optionality depending on local health needs. So
that's deliverable. So what you're saying is you've got a sort of core service.
Yes.
You think, okay, the space is going to do this.
Yes.
And then depending what the 250 different centres say, we can option out that amount of space.
Absolutely right. And importantly, that space that is designed needs to be used by different parts of the NHS for different services. It needs to be flexible enough to do that, and we can build that.
We can build that.
Yes.
Amazing. Becky, do you want to come in?
So I think I would add to that, though, that this is not just about moving NHS services, because the Neighbourhood Health Centre is not just about lifting and shifting hospital services to a different location.
Oh, and do you think that's understood? Or do you think that's being planned for?
I think it varies.
Okay.
I think in some places, yes, they do. I think my experience and talking to people in the system is that one of the reasons we get a lot of underutilisation of existing buildings is because of not just the inflexibility of the space, but the rules around finance, the rules around governance and accountability. Yeah, I think that's absolutely key. So I think it is quite difficult to design spaces that will work for lots of different organisations, not because it's technically difficult to design those spaces. That seems to be easier to do. It's very difficult to make the rules work to use that space in a way that makes sense, that voluntary sector organisations can afford to use it, that GPs get their rent reimbursed. All of those kinds of things feel really important.
No, I absolutely hear you. So it's not necessarily a space issue. You can absolutely design. You sound very good at designing different spaces, but it is a case of what we can allow to go into that space based on who's using it and what their terms of reference and sort of various governance issues are. That's really clear, and as Chair says, we'll come to that. So I just want to go to developing guidance for systems to inform estate planning. And the government is currently developing this guidance on how to integrate national health centres with community diagnostic centres. And so I just wondered if you had thoughts about what this should specifically contain. So I don't know if Beccy wants to start with that, or Ruth.
I guess the only point we'd make on the CDC is that an awful lot of the CDC development still seems to be happening on acute hospital sites.
Yeah.
It seems to be a lot easier for that to happen, and I think one of the risks about of combining those programs is making sure that neighbourhood health is not a neighbourhood health centre that's still sitting on an acute hospital site.
Do you think there's a risk of that?
Yes, I do.
Okay,
not
Martin,
everywhere, but yes.
Okay, in the sites that you've identified, presumably they don't sit on hospital sites.
That's right, and the CDCs that we have delivered and are continuing to deliver are generally not in acute sites, but it's not. We are involved in primary care, so and there's several opportunities to do more of those.
Okay, and when you say it's easier for CDCs to be delivered on hospital sites, just for the record, can you say why that is? What the barriers are to getting them out into the neighbourhood?
I think often with hospital estate it's just much more flexible. It's easier for the NHS to develop on those sites because they often own those sites. I don't know much more about the technicalities of it, but it seems to be, I think also the demands and the pressures of having extra diagnostics on hospital sites because their own diagnostics is quite under pressure. I think there's a real business case for them to want to use that setting too, and also for staffing purposes. Yeah,
and is there anything that can be done to incentivise it to come out of hospital sites? I think that's not being done that would make it easier for them to allow CDCs to come out into the neighbourhood.
I don't know enough detail about that. I don't know if Ruth, you know more, but
I mean, I think what I would add in terms of what are the right services to move, I think it comes back again to Martin's comment about clinical strategy, although I would call it, what is the plan for what's the future service model for these communities?
Does that feel clear to you, Ruth?
I think it's work in progress.
Okay.
So ICBs are working on their neighbourhood health plans at the moment. Mm-hmm. Those plans have to engage with the local authority. They have to be signed off by health and wellbeing boards. So that helps with, this isn't just an NHS problem, this is a cross-government issue.
Do you think that will happen? Do you think it will become a cross-government? Because we all know how difficult it is to work across government, and I think, Beccy, as you said, at the moment ICBs are reducing in size, devolution is happening for many areas, local government reorganisation is happening for many areas. Do you think cross-government at a regional level is possible to allow these neighbourhood centres to come together in a really holistic way?
I think so long as the framework is there to that directs them to work together, which is what I think we've got through the neighbourhood health framework. I think a lot of it comes back to local relationships and the willingness for people to go outside their boundaries and talk to other people that have a real stake.
And being slightly cynical about that can be problematic, especially in today's world where people feel slightly threatened by job security or perhaps where things are changing fast. That can be problematic, getting people to be more flexible and creative in jobs.
This is the heart of the problem of the Neighbourhood Health Service, in that it to work well, its success relies on people from across different organisational boundaries, and when every organisation is being measured on its own performance, that's where its focus is. So, where is the incentive for Acute Trust, for example, to really take risks and move services out when the demand may still end up coming in? Where is the funding to build capacity in primary and community services? It's not there. We're relying on a shift in resources, but there's massive risks all around all of this. So the bit I don't think we've got right yet is getting people bought into the vision of what we're trying to achieve and the how, and this comes back to financial frameworks and the contracts, and that joined up plan around everyone's role. But the bit I was going to add on the specifically around CDCs and neighbourhood health centres, I think that, there's two others that I would mention. We've got a new hospital programme. We've got the community diagnostic centres. We've got neighbourhood health centres. We've got neighbourhood mental health centres. And all of these have different streams of funding. They all have different plans. They have different timetables. But actually, when you look at all of that, it's all about the same thing.
And you couldn't have been clearer. Thank you very much. Sorry, Martin, do you want to add something?
Just add one more thing at a more practical level. I think what we see when we build a new health centre, depending on with different organisations occupying that centre, often they have specific demised areas. At a practical level, we could end up having maybe documentation in place that at a lead provider level that allows any organisation to use any part of that space, if it's flexible enough, when it's not being used. And what we find in really quite new centres is that the utilisation levels are low because it's not needed on a particular day by a particular organisation, and yet there's no access from another organisation that could utilise it. You've got to free that up. You've got to break down the slump.
Isn't it really? When,
Absolutely
and I know
heartbreaking.
all my colleagues here will have charities and organisations wanting to do great things and can't find space.
It needs to be opened up and utilised.
Yeah, absolutely. Thanks. And I think we all have... Definitely, we all have public buildings in our patch that we can't understand why they're empty when we've got people crying out for space, and I think you've really identified that. Thank you so much. Thank you, Chair.